This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here, and I'm joined today by our research fellow.
And I'm Dr. Ilara. Today we're looking at a fascinating new study from the Journal of Neuro-Oncology, published in 2026, titled Motor Mapping to Enable Resections of Peri-Rolandic Diffuse Gliomas. It comes out of the UT Health Group in Houston, led by James Trippett and senior author Nitin Tandon.
This is a topic that hits home for every practicing neurosurgeon. When we talk about peri-Rolandic gliomas, we are talking about tumors involving the primary motor and sensory cortex. It's that classic surgical tightrope, balancing the maximal extent of resection, which we know improves overall survival, with the absolute necessity of functional preservation.
Exactly. The study emphasizes that while preoperative imaging like fMRI and DTI are great for a general roadmap, they aren't substitutes for intraoperative motor mapping. That remains the gold standard because of its high sensitivity and specificity in localizing function. The real question this paper tackles is the choice of modality, awake versus asleep mapping, especially when looking through the lens of the WHO 2021 molecular tumor subtypes.
Right, because the biological behavior of a glioblastoma is vastly different from an IDH mutant glioma, and that might influence our surgical strategy. So, Ilara, walk us through the patient cohort and the methods they used.
They analyzed a cohort of 130 patients who underwent peri-Rolandic glioma resection. 54 patients had awake craniotomies and 76 were in the asleep mapping group. In the awake group, patients provide real-time feedback, which is vital if you're worried about speech or premotor areas. In the asleep group, they used neurophysiological monitoring, specifically motor-evoked potentials, or MEPs, elicited by direct cortical or subcortical stimulation.
And they went a step deeper into the asleep cohort, didn't they? Comparing the actual stimulation tools.
Yes, they compared two specific asleep direct cortical stimulation, or DCS, techniques. The first was the handheld probe, HHP DCS, which is applied directly to the exposed cortex. The second was the subdural electrode, or SDE DCS, which is a flexible strip electrode they slide over the motor cortex when the surgical exposure itself is limited.
That's a common clinical scenario. Sometimes the tumor is right at the edge of your opening, and you don't want to do a massive craniotomy just to find the motor strip. So, looking at the primary outcome, new or worsening neurological deficits at 3 months, what did the data show?
This was the headline result. The 3-month deficit rates were remarkably comparable. It was 5.6% for the awake group and 5.3% for the asleep group. From a statistical standpoint, that's a p-value of 1.000.
That's significant for those of us who might be hesitant to go asleep for a motor case. It suggests that if the patient isn't a good candidate for an awake procedure, maybe due to anxiety, seizure risk, or tumor location, the asleep mapping approach is a very reasonable alternative. But let's look at the secondary outcomes. How did the patients actually fare in terms of their performance status?
This is where the molecular subtypes, the WHO 2021 classifications, come into play. When looking specifically at glioblastoma patients, the asleep group actually had significantly lower preoperative and postoperative Karnofsky performance status, or KPS, compared to the awake group.
That makes sense clinically. Often the patients we choose for asleep mapping are the ones who are already more neurologically compromised or have a lower baseline performance. They might not tolerate being awake on the table for 4 hours.
Precisely. But the key takeaway is that the delta KPS, the change in performance status, and the 3-month deficit rates did not differ between the two modalities in GBM. Even more interesting, in the IDH mutant glioma group, there were 0 deficits at 3 months in either the awake or asleep groups.
0. That speaks to the efficacy of mapping in general, but also perhaps to the slightly more predictable growth patterns or different infiltrative nature of IDH mutant tumors compared to GBM. What about survival? If we choose asleep mapping, are we compromising oncological outcomes?
The study found that progression-free survival and overall survival were comparable between the two modalities in GBM patients, so choosing to keep the patient asleep doesn't seem to hinder the surgeon's ability to achieve an effective resection.
Let's dive deeper into the asleep techniques. You mentioned the handheld probe versus the subdural strip electrode. Residents often ask when to use one over the other. What did the study find regarding safety there?
This is a very practical point. The handheld probe, HHP-DCS, had a 3-month deficit rate of 3.3%, while the subdural electrode, SDE-DCS, was higher at 16.7%. Now, while that sounds like a big gap, the p-value was 1.24, meaning it wasn't statistically significant in this cohort. The author suggests that SDE-DCS is a safe and effective way to map when your exposure is limited.
That's an important nuance. Often, we use the subdural strip because the anatomy is difficult or the tumor has distorted the landmarks. The slightly higher deficit rate might reflect the complexity of those specific cases rather than a failure of the electrode itself.
Exactly. The paper also clarifies the functional interpretation of these responses. In an awake patient, you're looking for arrested movement during stimulation to identify the motor cortex. In the asleep patient, you're looking for the presence of MEPs. Both serve as a guide for resection boundaries.
I think for our residents and med student listeners, the takeaway here is about functional preservation. The study reinforces that while awake mapping allows for that real-time voluntary movement assessment, the neurophysiological feedback of MEPs in an asleep patient provides a comparable level of safety.
It also highlights the importance of the WHO 2021 molecular subtypes. By stratifying the results, the authors showed that our surgical goals and expectations should be tailored to the tumor's biology. If you have an IDH mutant glioma, your chances of a deficit-free outcome are excellent regardless of the mapping modality, provided you're using intraoperative mapping.
It's worth noting, as the authors do, that this is a retrospective study from a single institution. While it's a robust cohort of 130 patients, it doesn't establish statistical equivalence in the way a prospective trial would, but it certainly provides a strong evidence base for asleep mapping as a primary strategy.
They also mentioned hospital length of stay and discharge disposition, which are important metrics for hospitalists and administrators. These were also comparable across the groups, further supporting the idea that asleep mapping isn't lesser care, it's just a different tool in the kit.
Any final thoughts from the paper, Alara?
Just that the authors really emphasize that the choice between awake and asleep should depend on tumor location, patient suitability, and surgeon preference. They've shown that we can feel confident in our neurological outcomes with either path.
That's a great summary. For those listening, remember that the goal is always maximum safe resection. This study gives us the data to support tailored surgical planning, whether the patient is providing us with feedback while awake or we're relying on those MEP signals while they're under.
It's a great addition to the literature on Peri-Rolandic gliomas.
Absolutely. Well, that's all the time we have for today. Thank you for diving into the data with me.
Thank you, Dr. Aris.
We'll see you next time on the Neurosurgery Hub podcast.